And actually, so the way that I got introduced to Ashwin is that he is a geriatrician from UCSF, University of California, San Francisco. And he works very closely with another geriatrician. Her name is Carla Parasinato. You may have heard their names in kind of conversations around all of this. They started something called the Coalition for Social Connection at the federal level. And they have the ear of a lot of people, policymakers, Surgeon General, others in the field. I won't steal your thunder. Ashwin's going to talk about a lot of really cool things that get me very excited. So let me just introduce you and I'll let you do your job. Okay. So, wait a minute. Ashwin is an assistant professor of medicine in the Division of Geriatrics at UCSF School of Medicine. He's also attending on the inpatient palliative care service and the outpatient palliative care clinic at the San Francisco VA Medical Center. Dr. Kotwal devotes most of his time to research, focusing on understanding and enhancing social connections of older adults to improve their quality of life and healthcare access. Recent work has investigated experiences of loneliness and social isolation among older adults with cognitive impairment and the impact of the COVID-19 pandemic on social well-being. His research interests involve evaluation of community-based interventions, hello, we are one of those, to address loneliness and isolation, particularly among older adults with cognitive impairment or approaching the end of life. Ashwin, thank you so much for being here. Come on up.
Thank you so much, Kate, for the wonderful introduction. And really, I have been thrilled to be invited here, not just as a speaker, but as a learner. I feel like every person I talk to has taught me something new about the Village movement and just the innovation that you all bring to the table here. And I agree, what's a space that has a lot of players, but I think the Village movement can make a huge difference. And so I'm going to be coming to this topic as a geriatrician and a palliative care physician, kind of what I see as a clinician in my day-to-day experience, and the importance of bridging the medical and social care that we provide to people in our communities. And here are my disclosures. I won't be discussing anything related to commercial sources today, and most of my funding is from the National Institute on Aging, the California Department of Public Health, and the National Palliative Care Research Center. All right, so I'm going to flip things on its head a little bit today and start with our key message. I'm going to give you a lot of data, and I hope that you keep this key message in mind. I hope they'll crystallize, and we'll also build from this key message as we have more discussions. So here it is. Loneliness and social isolation are markers of our overall social well-being and greatly impact older adult health and efforts to age in place. The Village movement is on the forefront of addressing these social needs, and continued innovation and cross-sector collaboration is critical for lasting impact. That's an ambitious take-home message, perhaps. So here are some of the learning objectives that will hopefully get us to that message. The first is, how are loneliness and social isolation defined, and what are the health effects? This is an area where you all have a lot of expertise. And so I'll be trying to just get us on the same page and using similar language about how we discuss these topics. The second is, how are experiences of loneliness and social isolation uniquely affected by aging? And here I'll draw on my clinical experience. And the third is, how can we support older adults experiencing loneliness and social isolation? And we'll brainstorm together about collaborative opportunities to address these needs, trying to bridge these two sectors. So first, definitions and health effects. So to back up for a second, these topics receive a lot of attention in the media. Here's a collection of headlines that were drawn before the pandemic, where it was loneliness described as an epidemic. as deadlier than obesity or smoking cigarettes. Our Surgeon General, Dr. Vivek Murthy, took this on as his major defining issue. He released a book called Together where he outlines the health effects. And across the world, we're seeing this as a global challenge. The UK has a minister of loneliness, as does Japan. People really care about their social lives. I became interested in this topic during my geriatrics and palliative care training. I was learning a lot about how to provide really good medical care for people as they age. And I noticed that when people experience loneliness or isolation, it is a really fundamental source of suffering, that our clinical practice was nearly fully ignored. We learned a lot about how to provide good medical care, but I wondered about how we could bridge this divide between our clinical priorities, what we were seeing in clinic, and what the public actually cared about. And I wondered if there was an opportunity here to really improve people's quality of life. And I think one of the challenges here is if you start to look into the research in this space, the literature, you get inundated with all these different terms, right? And so it can make anybody a little bit nervous just trying to get your handle on what's going on here. And that's one of the reasons why loneliness and social isolation have really emerged as these two overall markers of the well-being of our social life. Loneliness refers to the subjective assessment that social relationships are lacking. So kind of that feeling of being left out, lacking companionship. You can feel lonely in a crowd, right? So you might be surrounded by other people and still feel lonely. On the other side is social isolation, this objective measure of connections to family, friends, and the community. So people may have a real lack of contact with society, which refers to social isolation. These are related but relatively distinct concepts. Very few people actually experience both. And it fits along an overall spectrum. On the left, we think about the subjective and functional aspects of our social networks. What are the resources that they provide? And on the right-hand side, we think about the objective and structural aspects. I'm happy to go into this further, but I think the key take-home point is that loneliness and isolation are these key markers of our social life. So with those definitions in mind, let's start to get the wheels turning a little bit in the room, because I know a lot of you are experts in this area already. So turn to the person right next to you and pair up. With your partner, think about a person in your community, work, who experience loneliness and social isolation. I couldn't even get through the whole prompt before you. That's great. So I think we have time for maybe two groups to share. Is there anybody who wants to share what they were, what kind of came to mind?
They're begging me. Hi, Amy Stuck. I work at West Health, but I'm also with our Encinitas Village. And recently, we were providing services to somebody who was really clear that she was lonely, very lonely. And even though services were being provided, she was still asking for more services, and we even hooked her up with extra help. So our question was, is when you come across someone who's subjectively lonely, even though they are in a village, getting village services, and with the addition that they have a difficult personality, for even people to spend time with them, is that where you sort of get into more, like behavioral cognitive therapy or something like that? Because it's really that internal feeling of being lonely that needs to be addressed as opposed to the structural. Anyway, feel free to comment on that.
Yeah, absolutely. Thank you, Dr. Stuck, for bringing that challenge up. And I think you're right. I think there's a lot of people don't arrive at loneliness in one way. I think they bring a lot of their life experiences, even prior life trauma can contribute to some of those barriers, internalized barriers that people put up to making social connection. And so it's really critical that we meet people where they're at. So you all were providing the structure. that she can connect with others. And what she needed was, complementary support from probably a psychologist to help with what we call maladaptive social cognition, which is a situation where people have lost the ability or have created, who have challenges to normal social interaction. So if you're not really a pleasant person to be around, it's hard, right? And we need to work on that. But there are ways of addressing that. So I'm glad that you brought that up. Yeah, we'll talk about that. I think we have time for one more.
Yeah, so we talked about members in our 2 villages who have MCI and how difficult it is early onset when people have MCI, but they are young enough that those around them might not necessarily understand that that's why they can't engage, and so then they self-isolate because they're not able to keep up with appointments or meet friends when they said they were going to, that sort of thing. So yeah, just that kind of sort of early onset MCI and dementia and how it can isolate you.
Thank you for sharing that. We'll be talking a lot about that in the upcoming slides, so it's a great segue. So let me, I think these topics, there's a whole scientific conversation that's happening around this, but there's so many stories that we can tell around loneliness and isolation, which I think are most helpful, at least to me, in grounding this in the real world, because a lot of the solutions are right around us. So here's one real life experience I had in clinic, actually early on in my palliative care training, that brought this topic to life for me. This is Bill Smith. I've changed the name and a lot of the details to maintain confidentiality, but he was seen in my palliative care clinic. Palliative care is a specialty focused on trying to optimize quality of life for people with serious illness. So he was an 84-year-old veteran. He had mild cognitive impairment, was just brought up, chronic lung disease, and he was recently diagnosed with an advanced colon cancer. He was started on chemotherapy by my colleagues in oncology, and he was being seen in my clinic just to help address symptoms like nausea or diarrhea that can come up with chemotherapy. So he came to my appointment after he previously had missed an appointment. He was alone. He hadn't told anyone else about his diagnosis. He had no chemotherapy-induced symptoms, fortunately. He had no history of depression and a negative PHQ-2, which is a depression screener. And he had no emergency contacts, no advance directives, and no medical or financial power of attorneys. Now, many of you might be thinking, oh, I wish he was in a village, right? And I think even from an earlier step, we might be thinking about what are the social challenges here that are contributing to his clinical care, and is he lonely or socially isolated? So let's come back to our definitions. Loneliness is the subjective feeling of being alone. It's the distress that results from discrepancies between ideal and perceived social relationships. And so this is a subjective experience. So we don't know if Mr. Smith is lonely or not. Ultimately, we have to ask him. But again, this is something that we can't make assumptions about. Many people, even with or without relationships, can feel lonely or not lonely. How do we ask about loneliness? There's a lot of stigma that's attached to this experience. One of the silver linings of the COVID-19 pandemic is that so many people felt lonely during that pandemic that it's really opened up the conversation around this topic. So I typically just keep it simple. How often do you feel lonely? There's also research tools that we use, like the UCLA 3-item scale, which I have here. It asks people if they feel left out, they feel isolated, or they lack companionship. And it's graded on a 0 to 6 point scale, with 1 point or higher being occasional loneliness, and 4 points or higher being frequent loneliness. And when we use these types of scales, we found that loneliness is common across the lifespan. So on the right, you'll see 43%. So over 40% of adults over age 60 report occasional loneliness in the United States. And about 10% meet that 4 point or higher threshold, reporting frequent loneliness. And it's common across the lifespan. So on the left-hand side is the frequency of loneliness across the lifespan. And you can see early on, here, and loneliness is much more common in adolescence and early adulthood compared to prior. There's a little bit of a bump in middle ages, and then at the age of 70, it becomes an increasingly common experience. As a clinician, I often had to make the case to other clinicians that you should care about it. But in recent years, in the recent decade or so, there's been just a proliferation of research which has shown loneliness is related to health outcomes. Here is one of the first studies published in the medical literature by my colleague, Dr. Personoto. They conducted a national survey of about 1,600 older adults, those over 60. They followed them for 6 years. They used that scale that I just presented to you, the loneliness scale, and they looked at different health outcomes. What they found was that loneliness was really common, about 40% of older adults. About 2/3 of individuals who were married reported occasional loneliness, and only about a quarter of people living alone reported loneliness. So just because you're living alone does not mean you're lonely, right? And those people had worse health outcomes. They had a higher rate of death, premature death, 23% versus 14%. And they had a higher rate of ADL impairments, so functional impairments that could impair people's ability to get through their typical day. Things like toileting, getting out of bed, walking, 25% versus 13%. This study kind of blew the lid off of what sociologists, psychologists had known for decades, that these social aspects are critical to our health. And since then, there have been thousands of research studies that have cited this paper, and many more that have shown its relationship to other health outcomes. Why is this happening? Loneliness is not a disease. This is part of the human experience, right? But when we don't have an outlet to quench that thirst for social connection, that's where we can run into problems. When people have chronic loneliness, they're lonely over many years, that can set off a stress response in the body, activating the HPA pathway, the hypothalamic pituitary adrenal axis. Cortisol is the end product, and when people have chronically high cortisol, it can cause a wear and tear on our body, disrupt our sleep, our motor function, and cause chronic inflammation. What we also know is that when people are lonely, their receipt of medical care changes. They seek care in different ways. They may not end up in primary care as much. They may end up in the emergency departments, and that can cause changes over time. Okay, so for Mr. Smith, let's go back. We administered a pre-clinic questionnaire. I know pre-clinic questionnaires are everybody's favorite things to do. And we actually had a UCLA loneliness scale on there. And he scored 1 point, so occasionally lonely. And when I brought this up to him, this actually started a whole conversation about where he gets support. And he mentioned his cat of 12 years, Yip Yip, who is just this wonderful companion. Doesn't really help with his cancer care, but is a great social outlet for him. Okay, so let's now turn to social isolation. We define this as a complete or near complete contact, a lack of contact with society. It's a quantifiable number of relationships, so you can actually tally it up. How many children do you have? How many friends and relatives do you have? How often are you going to church or religious services? As you can imagine, it gets complicated really quickly. One of the tools we use in clinic is just looking back over the last year, who are the people you talked with about important things? If people can't name too many people, they might be socially isolated. I'll also just mention that you all likely pick up on the features of social isolation just through talking with people. And so this is not as complicated as it needs to be, or as we often treat it in research. When we use standardized scales, about 1 in 5 adults over 65 are socially isolated in the US, which seems like a high number, but actually may be an undercount because we often don't capture socially isolated people in research. And social isolation is similarly related to health outcomes, just through different mechanisms. So here was one of the first studies which found that social isolation was strongly related to mortality in a group of about 6,500 people. It's been replicated many, many times. And here's one of the studies that received most of the attention, actually attention from the Surgeon General on the right. But it was conducted by Dr. Julianne Holt-Lunstad out of BYU. She compared the association of social connection with with mortality, with death. And compare that to other leading public health risk factors. And what she found was on the top, those bar graphs show the relationship of social connection to mortality. You can kind of see how large that bar is. And below are other leading public health risk factors like smoking half a pack of cigarettes, obesity, avoiding air pollution, which is all the way on the bottom. So it received a ton of attention because people realized, oh my gosh, social connection is just as important as things like smoking half a pack of cigarettes for physical activity. Why is this happening? Social isolation is not necessarily emotionally distressing to people, but I increasingly think of social connection as a health aid. When you're socially active, you're doing things that facilitate healthy behaviors like physical activity. You might be less likely to smoke or use substances like alcohol that might be negatively impacting your health. And probably most important, when there's a crisis, you have somebody to turn to, right? If you lose your job, you can turn to somebody to help get you through that period so you don't lose your home. If you're hospitalized or you're diagnosed with a serious illness like cancer, you have somebody who can help you get to your appointments and get through challenging medical treatments. And there's the emotional support for new onset depression or anxiety. So let's turn back to Mr. Smith. We decided to really delve into his social life. We learned that he lived alone, he was divorced and had no children. He has no close friends, noting all of my friends have died. He's unsure how to use a video device or a smartphone. He wishes he could give back to other veterans, something we always hear, that people want to give back and volunteer. And when we asked about a medical power of attorney and emergency contact, he said, "Can you all be my medical power of attorney?" I'm sure you're seeing all of these things as potentially aspects that the village can help with. And just to summarize his social situation, he's occasionally lonely and he's quite socially isolated. So coming back to this Venn diagram, he's more on the right-hand side of this Venn diagram. Okay, so hopefully we're clear, we're speaking the same language in terms of definitions and thinking about the health effects. Now let's think about how experiences of loneliness and isolation are uniquely affected by aging. And here I'm going to draw on my clinical experience. And I'm also just want to put out there that I strongly believe that aging experiences are diverse. And so what I'm going to be presenting is when things start to go wrong as people age and how we kind of address those things, how it really impacts the social connection. So to take a step back, geriatricians' approach to the care of older adults is very different than the rest of the medical field. And I think part of the reason is because there's a lot less evidence and research among older adults. They're often excluded from research studies, but also because we start to think about situations that aren't related to any one organ system. Not just related to the heart, not just related to your kidneys, but related to how everything is interacting together. And so we draw on this framework called the 5 M's: mind, mobility, medications, multi-complexity, and what matters most. And so for mind, for example, we might be thinking about how do we manage dementia or depression? For mobility, how can we improve people's gait and avoid falls? For medications, how can we take a patient-centered approach to medications where we're both prescribing medicines that make sense, but also stopping the medications when they accumulate too much or are causing more harm? Multi-complexity is about how everything interacts together, and what matters most is how do we align people's values with the healthcare that they're receiving. So what does matter most? When we've done studies of older adults, many of whom maybe even in the last years of life, we asked, there was one very famous study conducted in 2000 by Dr. Karen Steinhauser at Duke. She asked people and their caregivers and clinicians across all of these different domains, what matters to you? Is it being out of the hospital? Is it being out of pain? And what she found was that social care or social needs emerged as the highest, if not at least equally, or if not the highest priority for people, even when they're diagnosed with serious illnesses. So they reported wanting to have someone who will listen, sharing time with close friends, the presence of family, and even being able to help others up until the last months of their life. In some of our research, though, we found that when people have a serious illness or are in the last years of life, they're more than twice they have more than twice the likelihood of loneliness and social isolation. Dementia and advanced lung disease, for example, are highly related to loneliness and isolation. And so I think what we're all understanding here is that loneliness and social isolation are not unique to older ages. This is something that's experienced across the lifespan. But there are unique considerations at this life stage, and we really need to think about how to adapt, help people adapt when things might go wrong. Because there are many losses that are highly predictive of loneliness. The death of a spouse, largely considered the most intimate relationship. The death or loss of relatives and friends. These are relationships that are difficult to replace. People don't want to replace these relationships. Changes in living arrangements or institutionalization, and of course changes in our health, deteriorating physical health, mobility, impaired vision or hearing, and reduced opportunities to socialize. And these things aren't just happening on their own, right? There's a whole life experience that is contributing to experiences of loneliness. So we've done some work on the experiences of early life trauma and how that might contribute to loneliness later on. And I know there's a lot of data here. What I'll just draw your attention to is what I have in that red box, the loneliness, which is in the left. So what we did was we looked at early life trauma, things like exposure to military service, the loss of a child, an earlier diagnosis of serious illness. We created a scale looking at, from 0 to 10 lifetime traumatic events. And we found that people with more traumatic events in their lifetime were far more likely to experience loneliness in the last years of their life, 12% to 22% for someone with 5 or more traumatic experiences. Loneliness and isolation also impact our ability to age in place. They increase our likelihood of becoming functionally impaired, frail, or homebound. They require early nursing home. People who are isolated require early nursing home assistance. And about 50 national and global studies have linked loneliness and isolation to increased rates of cognitive impairment. So here was one of the first studies on the right-hand side where it showed that people with low social integration experienced more rapid declines in their cognition compared to people with high social integration. People are more likely to experience poor quality of life. One study out of University of Michigan found that people who are lonely experience higher rates of pain, anxiety, depression, fatigue, and the cluster of these symptoms. And some of our work has found that people are more likely to use the medications related to those symptoms if they're lonely, right? NSAIDs, antidepressants, anxiolytics, opioids, and polypharmacy, more than 5 medications at a time. And I just want to spend a little bit of time on thinking about how cognitive impairment can impact these experiences, because I think this is a growing population in the United States, and one that the Villages has a unique, potentially a unique role in helping to support. So older adults with cognitive impairment have much higher rates of loneliness and isolation compared to the general public in the United States. Here's some of our work which has shown that people who have cognitive impairment have higher rates of social isolation, 18% up to 26%, as well as frequent experiences of loneliness, 16% to 26% as well. And what we found is that when people are experiencing cognitive impairment, they have a harder time keeping up with healthcare services. So we conducted a study, there's a lot of data here. Just say we conducted a study, we were really interested in how do people who are socially isolated experience healthcare when they're getting sicker. What we thought was that if you don't have support, you're gonna end up in sicker situations and end up going to the emergency department or the hospital in kind of dire situations more frequently. What we found instead was that people who are cognitively impaired and isolated actually end up using less services. They're less likely to be in the emergency department, in the hospital, in our intensive care units, or even to use things like hospice at the end of life. Now, you might be thinking, is that a good thing? Are they avoiding healthcare? Is that great? Should we be celebrating? I think there are a lot of reasons to be concerned here. And a sociologist out of UCSF, Dr. Porticolone, points to two major reasons. The first is when people start to develop cognitive impairment, they may have a preference to actively avoid healthcare and social activities. And part of this is stigma and shame. They want to conceal their impairment from others, but this may also be related to a lack of insight that they have in what's going on. The second reason is a lack of tailored services. So I don't know if any of you all have experience navigating our healthcare system, which is just a dysfunctional mess, right? And you can imagine that this is especially hard for people with cognitive impairment who are on their own. There's a lack of tailored services. And she provides this example of losing your driver's license, which can just be a complete loss of a lifeline, right? I'm thinking about people up in Humboldt County, right, who we often serve through the VA. If they lose their driver's license, it's almost impossible to access care. And so we really need to be thinking about this group as at risk of falling through the cracks of our health system. And how can we mobilize external services to get them where they need to when they're having issues? Get them transportation, get them to their appointments. Oh. All right, we've also had the privilege of being able to interview a lot of people, not just people who are experiencing cognitive impairment on their own, but also their family members. And so we interviewed about 20 people living with dementia, as well as their care partners over the last few years. And we picked up that their disease process is really uncomfortable because of its major effect on people's social lives. That turns out to be one of the most important quality of life issues for people experiencing dementia. So here's one person we interviewed who's diagnosed with Alzheimer's disease, who said, "My wife notices that my memory is not as good as it used to be, or should be. Psychologically, it's a big downer to know I have Alzheimer's. It's embarrassing. I think of people that have Alzheimer's as just slobbering babbling idiots. It's social, the same thing. Why would I want to go out and look like a slobbering babbler?" And so this was a person who was really withdrawing from his social circle. And here's a quote from a daughter who said, "My dad, especially when my mom was gone, was very scared and emotional and labile and easy to trigger. And so a couple of friends came by and got sort of scared off and started to get the feeling like, I'm not helping by being here, so I just won't come. So very quickly, people didn't come. And so he was pretty lonely, except for the caregiver and my family. I mean, very few visitors." Dementia can also greatly disrupt the intimate spousal relationship. Here's one spouse who said, "The emotional stress is very debilitating because as I've always said, you're taking care of someone who's the love of your life. And so you're losing that core relationship by becoming a caregiver. But you try to cling to it and they can't respond to it. And it's just this back and forth struggle to make sense of this relationship that you're now basically a nurse for." And here's one last quote. I know that these are powerful experiences. This was a spouse who was describing the change in living situation. So it was harder for me than it was for spouse. Spouse adjusted to assisted living over the course of a few months, but my husband leaving home was one of the saddest, if not the saddest day of my life. And then coping with that, with him still being alive, but not being able to be at home, it was very lonely. It was much more difficult for me being lonely, and I was exhausted from caring for spouse at home. When we looked at national married couples data, we found that this lines up with the interviews that we're doing quite well. People who are married to spouses who are living with dementia have higher rates of loneliness, shown in those first bars, higher rates of depression, and both of those experiences. And we've also looked at the experiences of persons living with dementia who are nearing the end of life. And we found that spouses start to experience the bereavement process even prior to the death of their partner. And so they have higher rates of loneliness before the death of their partner, and it kind of equalizes after the death of their partner compared to people without.
at around half. And I'll just say that this is 2 years after the death of their partners, and so the bereavement process is not this simple process that people go through. The grieving process is something that becomes a part of their identity. Okay, that was a lot. Thank you for going through that with me. These are experiences that really draw on my day-to-day clinical experience. And I think the next step here is thinking about how we support people, because ultimately this is about improving people's quality of life in a way that is highly meaningful and impactful to them. So, I did it again. All right, so this is a huge topic of national conversation right now. The Surgeon General released a report in 2023, or epidemic of loneliness and isolation. And this, Kate mentioned this earlier, he really called for cross-sector collaboration to address this issue. And I'll just mention that pillars are strengthening social infrastructure in local communities. That's the first pillar. That's what you all are doing. Enacting pro-connection public policies, mobilizing the health sector, reforming digital environments, deepening our knowledge, and ultimately building a culture of connection. Exactly, yes. So our next pair up activity, turn to your partner, same partner or different partner. Think about opportunities to improve our support for older adults experiencing loneliness and isolation. What is the biggest barrier that you see, and what are you most excited about? And this will also feed into the World Cafe discussion. Let's return in about 5 minutes.
What's the new question?
Well, I hope everybody has a plan now, or at least concepts of a plan. All right. So would anybody like to share some of the opportunities that they're excited about?
We don't have time for
I think we probably all come to agree that the barriers are bigger than the answers. But building friendships was the thing we came up with, and no matter where you're at, build those friendships. And if you can move in with a family member that might need help, and you might have a family that's younger and whatnot, might be the answer. But keep those friendships going, build those friendships, make those calls, send postcards, make sure that people remember you and you remember them. Birthdays. Facebook's really good about remembering birthdays.
We were talking about supporting caregivers and people who've experienced loss, and how the village, our village of Pasadena, and I've seen in other villages, does a really good job for those caring for someone else and those who are in that grieving process that, like you said, lasts so long for your life, especially with these relationships that you've built. It gives you a sense of that, how important that relationship was, but also that an opportunity to think about what's going to fill some of that gap that that person left in your life.
Thank you for sharing. Yeah, I think this is an area where I think so many of you are experts in this space already. And so what I'm going to be sharing are some of, I could speak all day, I think, about some of the opportunities we have to make a difference in people's quality of life. But I'm going to talk about 3 specific opportunities here to confront some of the key barriers. So the first opportunity I think we have is to better identify people we are missing through this incredible intervention, incredible social programs that you all have. The first area where we might be missing people is people who are experiencing loneliness. And that's a lot of what we discussed before, the stigma, the shame that people can attach to that experience can make it difficult to talk about. And so what I found is that just normalizing this experience can help to make it an open conversation. So in my clinic, I'll say things like, I've noticed that many people have been feeling lonely recently. Is that something that you've been experiencing? This is just one way to get that conversation started. once you get the conversation started, it's going, and people really appreciate the space to discuss it. And I'll also just say, you don't have to have a solution to their loneliness. Sometimes people just want some space to process it. And I've often told people, I can see that this is really important to you. Let's think together about how we might be able to address this. And this might be a little bit of a trial and error process, but I care about this and I want to make it a priority. The second group of people that we're missing are people who are socially isolated, because by definition, they have very little contact with the rest of society. And so we're often missing them in research studies, we're missing them in our community programs. Social isolation strongly overlaps with other social determinants of health. Poverty, for example, is among the strongest predictors of social isolation. And so we really need to think about who are the people on the margins of our communities that we're missing, and how can we get a hold of those people? People with serious illness are also experiencing isolation at a much higher level because their illness might be taking over their life in a way that they don't want. And so we need to think about how can we bolster support for people when they're really in crises or in difficult moments in their life. Social isolation is also a hard thing to talk about, right? We work with a community partner who says, nobody wants to say, hey, I'm Ashwin, I have no friends, right? Instead, we need to normalize this and maybe start with, hey, do you need help connecting with others? I have a lot of programs here that we might be able to use to help. And the third area that we might be missing people is by setting. So we have these conceptualizations of nursing homes and assisted living facilities as places where people go and their social lives die, right? Where they have no contact with society, and we saw this in the pandemic so much that they were really living on the margins of our communities. But we've done some work that shows that when people actually go into nursing facilities, their social lives do not die, but certain aspects could be improved. So here's some of our data which shows people, their social lives before they go into a nursing home, shown by the red line. The x-axis shows time. So each line represents a different social activity. Visiting with others, going out for enjoyment, religious services, participating with clubs in the blue, and volunteering in the bottom line. What we found was that everything starts to decline before they go into a nursing home. But when they go into a nursing home, some things actually get better. They start to participate in clubs a little bit more, they start to go to religious services a little bit more, but we could do better, right? This could be something where we really reach out to nursing homes or assisted living facilities and try to keep their integration in their communities. Healthcare systems, as a clinician, I'm often on the front lines of seeing people who are very isolated in our emergency departments, in our hospitals. We need better communication between community programs and healthcare systems. Payers, so insurance companies have this broad lens, a broad view on who might be isolated. And so we've actually conducted some collaborations with a Medicare Advantage plan who are able to identify people at risk of being lonely. When we identified those people and connected them with a friendship line in San Francisco, they were actually able to prevent loneliness or reduce loneliness in a significant way. Okay, and then community leaders like you. You all have this inside look into who might be isolated in your communities. I've also had conversations with building managers, people who know about older adults who might be stuck in their homes, who might be homebound. And so having these open conversations, this collaboration is critical. Okay, the second opportunity we have is to quantify the impact of enhancing social connection on outcomes, which matter to funders and policymakers. So I was so glad to hear about the recent patient-centered outcomes research initiative, the PCORI grant that you all received in collaboration with Rutgers University. I think that's a first step to quantifying the impact, because we need to be speaking the same language as policymakers and funders. Can we actually reduce healthcare costs? Can we improve some of these outcomes that are relevant for policymakers? So AARP has shown that social isolation and loneliness contribute to $6.7 billion of healthcare costs per year. And some recent research out of Stanford showed that Medicare recipients who were isolated had $1,600 in additional costs compared to people who were not isolated per year. And so there are those costs that are already there. I think they're understated, but they're already there. How can we make a dent there? And the impact of aging in place, I think, is huge. And we need to be thinking about what are the health outcomes that are tied to aging in place and how can we quantify that. The last section, and this has a little bit of overlap with the prior identification opportunity, is coordinating with health systems and community programs. So we're working in a space where there's a lot of different players. Health systems, I think, increasingly care about this topic. They're identifying people who are lonely and isolated, and we're trying to make a push to address medical factors that contribute. So things like vision and hearing loss, functional impairment, pain, incontinence turns out to be one of the strongest predictors of isolation and loneliness, and depression, which is deeply intertwined. So when they are doing their medical things, how can social programs complement those systems in as seamless a way as possible? And then from a community standpoint, there's so many programs that are out there. How can we coordinate in a way where we're really building upon each other's works and enhancing the strengths of each program? Social prescribing is a topic that's getting a lot of press right now. I think it's an exciting area because it's about health systems which actively participate and make referrals to community organizations with expertise and awareness of programs that can enhance social connection. So how can we improve that referral process from a huge health system like UCSF to the San Francisco Village Group? You know, I think that's something that the health system is thirsty for and is and still needs a lot of work. And when we think about cross-sector collaboration, what element of social connection are we trying to enhance? So the National Academy of Sciences report in 2020 described 3 different domains of social connection: structural, functional, and quality aspects. And different programs might contribute to those domains differently. I actually think that when there's a lot of overlapping benefits to social connection programs, and so I think the key though here is that we need to individually tailor programs to people's needs. So as Kate alluded to, we've created a coalition in Northern California, the Northern California Coalition for Social Connections. UCSF serves as a hub for this coalition. There are similar coalitions in Southern California and in Wisconsin. But we've assembled about 50 different programs, including the San Francisco Villages, which are focused on addressing social connection, many of whom are doing this in different ways. So how can we coordinate, right? And how can we join the advocacy effort? Many evidence-based programs exist: peer support, intergenerational programs with which the villages are a leader at, telephone support, telephone support lines, exercise in group classes, volunteer opportunities. These all can reduce loneliness and isolation. And just a last word on technology, because this, people are reaching technology as the solution to everything. And I think the role of technology really depends on people's social situation and how we're using it. So some research before the pandemic found that it depends on people's social situation. If you're using it as a way to complement already deep offline relationships, then it can be really beneficial. If you're using technology as a replacement, though, for those deep offline connections, that's where we can run into trouble, because we more often than not have superficial online engagement. And then when people have a difficult time attaining deep offline engagement, then technology may also be useful. And I'm thinking about people who might be immigrants who don't speak English as a first language. Many of them still really benefit from their Zoom support groups, right? Or people from the LGBT community who might not have a robust community around them. They may need to look to online communities for more support. And from a learning technology standpoint, there are many older adults who want to learn, many who don't have any interest in learning the next new program, but many people want to learn and are excited. And we actively need to address ageism when it comes to technology. Both the internalized ageism, where people don't feel like they can learn these new technologies, but also the built-in ageism that happens so much in our technology, right? Who hasn't forgotten a password, right, or a login? And addressing some of these just ridiculous barriers would actually benefit everyone. And we've also found that group classes, when people learn together, these technologies can be really beneficial. So exactly what villages is doing. All right, so let's turn back to Mr. Smith. Mr. Smith was someone I got to know really well in my clinic. He lived for about a year after his diagnosis of cancer. And in that year, we tried our best to try to address the consequences of his isolation. We connected him with a case manager for coordination of his increasingly complex care. We had early discussions about what he would want if things were to worsen, and filled out advanced directives early on, got emergency contact. We were actually, because we started those discussions early, we identified some friends and family members who actually really cared about him. And were wondering where he had been. We connected him with support groups and volunteering efforts where he could actually share his experiences with other vets experiencing cancer and kind of provide emotional support for them. That was something that was really important to him. And lastly, we made an early referral to hospice services. Hospice is specialized care for people in the last months of their life. And often people receive those services way too late, maybe the last days or weeks of their life. And so we made a referral early, 6 months before his death, so that he was familiar with the people coming into his home and could put some friendly faces to what otherwise might be a very impersonal service. And so he was able to die with dignity at home. So coming full circle to our key message, hopefully I've convinced you of this key message. But loneliness and social isolation are markers of our overall social well-being. They greatly impact overall health and efforts to age in place. And the Village movement, I strongly believe, is on the forefront of addressing these social needs, and we need continued innovation and cross-sector collaboration for us. Thank you so much.
Okay, that was awesome, right?